scales that actually tell us about pressure ulcers. Various scales that tell us about pressure ulcers. Okay. So if you look at the flow chart, you will see there is a scale on the back. What is the name of the scale? Brandon score. It's called Brandon score. There are many such scales. There is NTU. There is many other pressure score ulcers that are there. Brandon score is what is there usually over there, which includes a lot of things. Okay, on the Brandon score. So, what are the causes that could lead to pressure ulcers in the ICU? You can be diabetic, anemic, Parkinson's, cerebral palsy, elderly patients, spinal cord injuries, hypertension, cardiac injuries, anything. Because it's not just immobilization. You might think that it's only immobilization. No. Any of these comorbidities are known to cause pressure ulcers. Okay, and the extrinsic factors that you can avoid is the extrinsic factors, which is shear, friction, moisture, immobility, bed sheet folds, incontinence, fecal and fluid nutrition intake. Now, how did this occur? Now look at this. The superficial of the capillary is approximately 25 millimeters of mercury. Any pressure more than that will actually lead to a reduction in blood supply to the skin and soft tissues. To the pressure source. Right? So there superficial pressure on skin at points where body weight is supported against gravity, and deep pressure exerted on the bony structures. There is a shear force due to distortion of tissues and a friction while shifting the patient. Clear? So the various reasons why we get a pressure stroke. You should know this, okay? Superficial pressure, deep pressure on the bones, a shear force, or a friction. When you say friction, one of the classical features of friction is you have a fold in the bed sheet, the patient is moved from bed to bed. So you can't fold a bed sheet and move the patient from bed to bed, that is going to cause. Similarly, when you're moving a patient from bed to bed, you don't use a pad slide or a roller. You just keep the patient and just move the patient from bed to bed. That is a shear force that is developing. Okay, so you can't move the patient from bed to bed without a pad slide. It is wrong to do that. Right? So this is pressure ulcers. So grade 1, grade 2, grade 3, grade 4. When you say grade 4, it means it is up to the bone. Okay, you can see the bone. When you say grade 1, it is just a erythema which can be plunging on pressure. Okay, then you have grade 2 and grade 3, which is variable stages between that, where one, the epidermis is broken and the other it is not. So first is blanching, second is not blanching, remaining permanent, third is the one when the epidermis is moved off, and fourth is when you reach bone deep, muscles and bone. So grade 1, grade 2, grade 3 and grade 4 pressure ulcers are there. And this position that we have, this position that we say the patient propped up, is probably the most difficult position to keep, because this is the most important position that causes pressure sores. So a propped up position that we think is something that is very important to be done in all our patients is actually the most dangerous position for a pressure ulcer, because the entire weight of the body lands on the sacrum and causes a pressure sore. Clear? Clear this? Huh? So that's why when you say propped up position, we have to keep it only for a defined period of time, don't keep it for a long period of time. That's why we have a 2-hour mobilization. You can't just keep the patient propped up. You have a patient BiPAP all the time, keep him propped up. There is a possibility of pressure sore developing, especially these diabetic, hypertensive, ischemic heart disease or vasopressors. If you are vasopressors, already there is vasoconstriction. The presence of vasopressors increases the incidence of pressure sores. Clear? So risk of pressure ulcer by risk factors actually goes on increasing. So if you are diabetic with something, then pressure ulcers keeps on increasing. So who gets a pressure ulcer? So it depends on those. So there are many scales. There's Costner scale, there's Waterloo, there's Braden's. This is Norton score. The Norton score, actually there are many scales. None of these scales are said to be very clearly saying that it causes pressure sores in ICU. They are scales that are verified in the wards. So this is an example of a Norton score, where it depends on the mental state, the activity, mobility, incontinence. Okay, depending on that, they put some limit. They put kind of numbers to it, and they give a cutoff of 16, which actually says that anything more than 16 will have a lesser chance of having pressure ulcer. Okay, even putting the patient on a wheelchair for a long period of time is kind of very dangerous, very disastrous it can be. So don't keep the patient on a wheelchair for more than 2 hours, or it's scary. It's not something you're supposed to do. Alright, so almost every patient of ours are at a high risk for pressure ulcers. So the lateral positioning also, if you look at the lateral positioning or the supine positioning, there are various places where you can have pressure ulcers. So every morning when you're checking your patients, you should be checking at points that are mentioned on this, which includes under the heel. That's why we want the heel patch to be there. Okay, under the sacrum, on the elbow joint, on the scapular region, and the occiput. Very important points that you're supposed to check every morning in all your patients. So check all these points to see whether there is pressure ulcers. Similarly, in the lateral position, it's the same position. You have near the ankle, you have near the knee joint, you have near the hip joint, you have the shoulder, near the ears. Okay, and the prone position we all know is the knee joint, the toes, the pelvis, the pectoral region, the shoulder, and the head. Okay, so these are the places where you should be checking every time you are doing an evaluation in the morning hours. In the morning hours, you are looking for bed sores. It's very essential that you look for these bed sores and you categorize accordingly. Grade 1, grade 2, grade 3, grade 4. You know what's grade 1, you know what's grade 2, you know what's grade 3. Right? The commonest sites to get a pressure sore is actually the ischium, 28%, as I told you. So, the common position that we use very often is the supine propped up position. That's why the ischium, sacrum, coccyx form the combination of the highest amount of pressure sores that you have in the body. Okay, so ischium, sacrum, coccyx, trochanter, and heels. These are the places where you have the maximum of the pressure sores. It is very important to ensure documentation of the Braden scores every alternate day. Okay, every alternate day. So Braden score is something you will look from the back. Open up the back of the sheet, there's Braden score written on that. Okay, and shear, flexion, moisture, sensations, mobility, and alertness. That's what the entire score is all about. Okay, that score is something you can document because if it comes in your exams, at least you know that these are the things that I'm going to use. It's like the GCS for bed sores. Back and affected areas have to be personally shown to the doctor, available for confirmation and further management. So we should actually, during a rounds turn and look at the pressure sores. Okay, then unstable pressure is too difficult. Okay, so how to prevent this? The entire thing is to educate. This is what we're doing now. We have to be educated enough to understand that if I keep a person in a position of more than 2 hours, there is going to be a pressure sore. This is first key. Regular examination. So sacrum, trochanter, ischial tuberosities, occiput, heels. Okay, has to be looked. There should not be any moisture. There should not be pressure. There should not be shear. There should not be stress. There should not be friction. It's very essential to look at all these points. So if a person is sweating, he has a very, 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 very high chance of having a pressure sore because it's moisture. So you can't have a patient sweating. If he's sweating on his face, means down will be sweating. It is important that sweating doesn't take place because moisture is something that can cause maceration. Maceration will lead to pressure ulcers. Ideally, every hour it has to be done, but at least we are training minimum every 2 hours it has to be done. That is why we have a body clock that we place at the bed end, at the foot end, and you have to follow the body clock. So every 2 hours you are changing the position. It's very essential. And this is more frequent actually. We say if it is patient is in shock, they should be more frequent positions because in shock what you're going to get, you're going to have the capillaries to be perfusing much more lesser. So shock. You have to follow a written schedule, that's what we're following as of now, following a written schedule. Okay. Now there are various kinds of support surfaces. Of which these support surfaces redistribute pressure evenly. Have you seen the support surfaces that we have? We'll come to that. We'll come to support surfaces. Okay, it's important to alternate pressure surface. Pressure is reduced every 4 to 10 minutes. The pressures are going to be reduced in these things. It's important to keep the skin dry by using talcum powder. Take care of incontinence, the wound discharge. Avoid a friction and a donut, a round tire, which they keep patients is completely not useful. It's not supposed to be done anytime. Okay, initially they used to put a small tire to where you're sitting to prevent pressure ulcers. You're not supposed to do that anytime. Donut is not useful. Now, which are the support surfaces we have usually? The support surfaces we have can be passive or active, of which there are two kinds of devices. You have a mattress replacement device and a mattress overlay device. The mattress replacement device and a mattress overlay. This is the common mattresses that we are having. Okay, there are many more mattresses that we have. What we are using is mattress overlay device. When you say overlay device means what are you doing? There's a bed, on top of the bed you're putting a mattress. There is a bed mattress, on top of that you're putting another mattress. Okay. Now what is the importance of this mattress? This is called as alternating air cell mattresses. So if you touch the mattress, you'll realize that at one stage there are various air cells in the mattress. At one stage you have this cell inflating, this cell deflating, then this cell inflating, this cell deflating. So you're alternating mattress inflation and deflation occurs. That's what you hear as a sound, a small word that you hear when you are having air mattresses. That's called air mattress. Clear on this? Air mattress. What happens is because it's alternating inflation and deflation, it actually evenly distributes the pressure across the skin. Now, as an ICU person, what are you supposed to understand? That it doesn't mean that you put on an air mattress means I'm not going to give position. Even if putting on the air mattress, it is very, very important to change the position. Okay. However, if the patient is fully conscious, it's extremely difficult to lie on an air mattress. If the patient is fully conscious, it doesn't make any sense to put them on the air mattress because it's absolutely difficult to sleep on the air mattress because it keeps on changing. You cannot sleep, you know, you're used to sleeping on a bed that doesn't move, right? But here the bed moves up and there's a change in the cell inflation and deflation, which makes it very difficult for a person to be comfortable. So if a person is fully conscious, we don't want the patient to be an air mattress. That's the first thing you must understand. The second thing is, when you put a patient on an air mattress, there is a very high chance, very high chance that the patient may move out, because if it's an overlay mattress, there is a very high chance that the patient may move out of the bed and fall off. Okay, because an overlay mattress will be added on top of a mattress. So be very careful when the patient is on an air mattress. The third thing is, and the most important thing I think for intensive care is to understand how to deflate it. Okay, it's very important. Why do you need to deflate it? Because of CPCR. During the CPCR situation, you can't achieve compression of the cardiac system if you do not know how to deflate the mattress. Once you deflate the mattress goes down immediately. So each one of you should know how to deflate. Do you know how to deflate it? Asha? No. You? Elizabeth? You know. You know? Sachin? You know. All of you should go now after this and find out how to deflate the mattress. It's very essential, because otherwise your cardiac CPCR you can't conduct. You can't do a CPCR unless you deflate the mattress. Okay, it doesn't work well, because at the end of the day CPCR is when you're actually moving the heart between the vertebral column and the top, the sternal bone. That is when you're going to move the heart. You're going to press the heart, compress the heart. So you can't do CPCR if you are on an air mattress, because it keeps on altering the pressure. So the other way to do CPCR is to actually, some hospitals don't deflate the mattress, they put another bed board behind the patient and they do CPCR. Okay, but now with the advent of new mattresses, with the advent of the way mattresses have come in, just pulling off the plug point actually gets it very quickly back into into deflated mode. Okay. So device, so in skin care, how do you do this? So every day morning, if you see that they do a lot of things in the morning during their shift, they keep the skin. You have to keep the skin clean. It has to be dry. It has to be lubricated by whatever creams that they are getting, aloe vera cream, this cream, that cream. So you have to do that. You have to lubricate the skin. Mild soap is sometimes is what they use. That is, they're using the pore-excited wipes, which is called detergent also. They rinse well and they pat dry. It's not rubbed. You don't rub it. They pat it dry. You're not supposed to rub it. You're supposed to pat dry anything. Okay, so it's pat dry. Avoid applying medications or chemicals. So we don't apply any medications or chemicals on the top to prevent a bed sore. Barrier agents are sometimes used. What are barrier agents? There are certain agents which are sprays that are coming. You ask when these nurses are checking for patients with urinary incontinence, you'll see them using a spray. That spray is a barrier agent that coats the skin, that prevents the skin from getting soiled, macerated, moisturized. It prevents that. It's like a plastic film, it actually sits on the skin. That's called barrier agent. So if the patient is having urinary incontinence, you should ensure that this patient is put on a barrier agent. Okay, a barrier agent which will prevent the ulcer from flaring up, getting macerated, getting all that things. That is one thing. So if you see the ICU clothes, they are not the usual clothes. If you see the ICU clothes, they are very different clothes. The clothes don't have thick seams. It's not like a jeans pant where you have thick seams. You don't have it. You don't have multiple pleats, snaps and buttons. That's why you don't get multiple buttons like normal buttons that we have. They don't have those buttons on them. You know, they're tied. Most of them tied. Why is it tied up? Because you don't want those steel buttons to be there when the patient is sleeping in bed, so na ho jaye usko. You understand? So that's why they don't have buttons. So the ICU paraphernalia is completely based on prevention of a pressure ulcer and ease of application, right? So avoid tight, constricting, very loose garments with elastic bands. That's why we don't have elastics. You might think elastic kyun nahi hai, isko nada kyun lage rakha hua hai. This is the reason for this. You don't have elastics because you want to prevent a pressure ulcer. Clear? Alright. So important. How do you prevent it? The most important, and I think the most important thing here is nutrition. It's very essential that we nourish our patients very well. We are not worried about the first 3 days. First 3 days we give whatever we want to give. After 3 days we start giving. So the first 3 starter feeds that we have is the same starter feeds all the time. After the first 3 days we start increasing the feeds that we have to require amount. So nutrition is very important. Okay, the moment why is it so important also? Because of the fact that most of our patients who come into the hospital will get IV fluids. Once they start getting IV fluids, they are lying in one particular position in the hospital, not upright. they are going to accumulate fluid in various parts of their body. As they accumulate fluid in various parts, the pressure that is there inside the skin is increasing. And when the pressure increases, you start developing a pressure sore. The pressure is increasing because of the fluid translocation that is occurring in all our patients because they are static, hypostatic, and at the same time they receive large amount of fluids. You understand? So nutrition per se helps to prevent all this from accumulating because it allows the muscle mass to remain the way it is and prevents translation. So it's very clear that if you don't nourish your patients well, they develop pressure ulcers. Hospital-acquired pressure ulcers are commonly seen in patients who are malnourished, who are not nourished very well. Okay, physiotherapy very essential. So these small things are very important in critical care. Physiotherapy, because what happens is the moment you mobilize them, the pressure gets evenly distributed. The moment they start moving their hands, the pressure starts getting distributed. The pressure gets offloaded from the patient every time the physiotherapist comes in and they move the patient. They do some exercises. It's not just respiratory physiotherapy that we talk about. We talk about physiotherapy all around. Okay, that is the reason that even if you have a patient on the ventilator, we want physiotherapy to be going on. Relatives may ask, physiotherapy क्यों कर रहे हो इसका? We are doing physiotherapy because we want to avoid a pressure sore, we want to avoid passive limb problems. Okay, so physiotherapy. We prevent insensitive areas from exposure to heat and cuts and bumps. Very important. You can't leave even a small cap on the bed. If you leave even a small stopcock or a cap on the bed, there is going to be a pressure sore for certain. For certain. Okay. So stopcocks cannot be left on the bed. You can't leave plastic wrappers on the bed. That cannot be done. It is not supposed to be done that way. By any chance, if it goes on to that, you are definitely going to have a pressure sore because it's a pointed area, not a flat area. It's an area that is in one point you have this pressure that's coming in. And safe transfers. You don't just transfer a patient from bed to bed just by pulling him from bed to bed. It is very wrong. Sometimes it so happens you have a bed, your second bed, and you say, "Chalo haath pakdo aur kheech lo usko." Never do that. That one instance will cause this patient to get a pressure sore in some 3 or 4 days time. Every time you want to transfer a patient, ensure there's a safe transfer either by using bed sheet, or bed sheet is not something that we advise. We use a pad slide for moving the patient from bed to bed. Right? Pad slide is what you want to use. Dressings. So people do use antibiotic, oral or topical dressings. We use that. So analgesics are done prior to dressing because it's very painful. Bed sores, unless they become insensate to that area, when it goes very deep down into the bone, it is very painful. So the dressings have to be done with analgesics prior. Debridement is something that we take the help of a plastic surgeon for. Not to use povidone iodine, iodophore, sodium hypochlorite, hydrogen peroxide, acetic acid. All these things are not supposed to be used. As far as possible, we don't use these medicines. You never will use betadine and all these things and dress the wound. It is never done. Pressure ulcers cannot be treated that way. So you don't treat it by using any of these medicines, povidone iodine, sodium hypochlorite, because it has cytotoxic effects. You will never use povidone iodine, all these things. And we use appropriate dressing materials. Appropriate dressing materials are available now where we can use them for preventing or treating a bed sore. That's why we don't use all these very harmful chemicals. Okay. So what do they do in debridement? In debridement, what they do is they remove necrotic tissue. And normally, if you want to clear also in the ICU, you want to clean the wound, you clean it with regular normals and Ringer's lactate. You don't use povidone iodine and clear the wound. Okay, normal saline Ringer's lactate we can use, and they irrigate with the 35-50 ml syringe. That 19 gauge cannula ke sath we push fluid so that it opens up. Avoid antiseptics again, povidone iodine, H2O2, acetic acid. We don't use any of these antibiotics. We keep the ulcer washed with saline soap gauze. Hydrocolloid dressings is what is used usually. What you're seeing over there, what they're using is hydrocolloid dressings, what they're using. Surrounding intact skin should be extremely dry. Very important that the surrounding skin remains dry. That's why we try to use those sprays and other materials where you have these staple bed sores that you apply. Those material that is coming out with patch, this patch, that patch, deodorant, all these things. These all have an area where there is a sponge with a hydrocolloid dressing and a round area that is plastic coated so that it prevents moisture and water from getting inside. The wound swab is not useful. Never do it. Never do a wound swab. Okay, if you have a patient who is having a bed sore, you never do a wound swab. Okay, if you want to figure out whether there is an infection, that will be like colonized. Whenever you want to figure out whether there is a bed sore that is infected, you take a tissue. Tell a surgeon to take a tissue out of it. You understand? You never will do a wound swab. Doing a wound swab for a patient of bed sore is just bullshit. Never do that. Okay, bed sore has, if you want to figure out if there is an infection and the bed sore is causing a problem, then you do a tissue biopsy. Okay, we take tissue biopsy, tissue sample, not the wound swab. Clear? It's very wrong to put a swab stick and take out a wound swab. It's wrong. Okay, it will be colonized. Okay, or it will contamination will come in. If there is persistent purulent discharge, then they give topical antibiotics, and skin grafting is done at a later stage. So, how do you know that the ulcer is getting better? If the ulcer gets smaller, less fluid drains from it, very importantly, less fluid draining from it, and healthy granulation tissue becomes visible. So, whenever they are opening up any patient, they are looking for healthy granulation tissue, red, RA ki nahi aa raha. If it becomes red and healthy, then we say that it is probably getting more healing very well. The surrounding area is very important. So, how do we do it in our ICU? When a pressure ulcer comes in, when a patient comes from outside, for example, and there is already a pressure ulcer, what are you supposed to do? It can be a very important source of medical legal compensation if you don't really figure out that there is a pressure sore. You can just say there is a pressure sore. No, the size of the pressure sore is very, very important. Size and depth. Size, depth, location. That has to be there. So if a patient comes from outside and has got a large pressure sore, you have to say that this patient has got a large pressure sore. This pressure sore is so much depth, so much size. The easier method to do that is to actually take a tegaderm or a green sheet, place it on the patient's back, draw it out from outside and stick it in the paper, in the file, and then write depth. Are you understanding? Take a green sheet, put the green sheet on the patient, and wherever the pressure sore is, mark it out as to how much it is with your pen, cut it out and place it on the paper, stick it on the paper, staple it on the paper and write down that this is the pressure sore that we saw on day 1. Are you understanding? That is what you are supposed to do, and take a sign of the relatives, because it can be one of the reasons to cause a medical legal problem for you. Okay, so pressure ulcer is a problem. It is something that comes because of us being there and not being taken care of. That is why it's important to note down the size of the pressure ulcer and the depth of the pressure ulcer. So whenever a patient comes from outside, you have to look at the back, you have to look at whether there is a pressure sore, and you have to write it down that there is a pressure sore, document with sign. The nurses do sign it. Nurses do take that consent. They have it on the first sheet when they write about it. But as doctors, we have to also write the same thing in our notes. Okay, that there is a pressure sore or pressure ulcer. How do we do it? Now we've understood it, right? So it's very important to maintain communication, because once you have a pressure sore that you have seen, it's important to get the physician involved. Who is the physician who is taking care of this patient, the primary physician involved, saying that there is a pressure sore that has developed. It is important that you know this. Okay, because it means that the overall condition of the patient is not good. You are understanding? So you see a pressure sore, don't keep it to yourself, let the person know the pressure sore has been developed. Physician nursing documentation should correlate. That's what I'm saying to tell you. If the nurse writes it, the physician also should write it. It has to correlate. Both of them has to say the same thing. You have to say the same thing if there was a pressure to begin with. Weekly, we normally look at the pressure ulcer to figure out whether it is coming down, increasing. And we have to revert plan of care if by any chance the wound has deteriorated or if there is no healing in 2 weeks' time. So it's important that you look, if there is a pressure ulcer, you look at it again. Don't rely on the nurse's view, because you also have to document it. You understand? Because we have to take remedial measures if required. So what we are doing is transparency. Okay, that means you're using a transparent sheet. That's what it's supposed to apply. People initially we used to take photographs, but we stopped doing that anymore. Okay, we used to do it with the iPad, but now we're not doing that. We're doing transparency. So putting a transparent sheet, we have to mark it out and put it down on paper. Name of the person noting down is supposed to be very, very important, and date of noting down is very important. Alright. Now what are the types of dressings we have? These are the types of dressings that I use. The hydrocolloid dressings, the hydrogel dressing, the alginate dressings, alginate patch is what you're hearing, silver-colloid dressing. These are the ones that are using composite dressings. These are dressings that we use whenever we are taking care of this. Deodorm dressing is what you normally hear, what you normally see. Deodorm is what you're normally seeing and what you're hearing. This is what you hear always. Deodorm. What is deodorm? Deodorm dressing is most closely resembles the shape of the wound. So you have different deodorm dressing for different parts of the body. Okay, so you have for sacrum you have one deodorm dressing, for the thigh you have another deodorm dressing, for the face you have another deodorm dressing. So each deodorm dressing is made in different shapes and sizes. So when you ask for deodorm dressing, it has to be made. You can't just buy it and cut it. वो नहीं कर सकते हैं, because deodorm dressing होता है उसके आजू-बाजू sticking का जगह होता है. समझ में आ रहा है? So deodorm dressing has to extend beyond the ulcer at least by 1 centimeter margin. It has to extend beyond the ulcer area by at least 1 centimeter margin and covered with plastic adhesive tape to prevent contamination and soiling. Okay, so the deodorant version nowadays don't require the plastic. You can just apply the whole thing and it will remain where it is. Clear? Deodorant dressing do not stick to the wound area, so it doesn't stick to the wound. It is the surrounding part of the duodenum that sticks to the skin. Okay, so duodenum dressing do not stick to the wound area itself. Therefore, the pain generally associated with the removal is greatly reduced or absent. That's why we use duodenum dressings. It doesn't stick to the wound. Clear? Necrotic tissue needs to be debrided. Okay, and that's why if you have a bed sore that is looking necrotic, darkish color aa gaya hai, quickly get a surgeon to have a look at it, because debridement is essential. Necrotic tissue means it will harbor difficult to treat organisms. It has to be immediately debrided. Expert opinion needs to be taken from a plastic surgeon or a general surgeon, because debridement in such cases may be required at more regular intervals rather than just once. Alright, any questions on bed sore? Any questions?